Hello, my name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy. Today, I'll be talking about the proposed physician fee schedule for 2022. Before we begin, a few disclaimers. Please know that any information provided in today's talk should be considered just informational purposes. It should not be considered legal advice. CCHP always recommends that you consult with legal counsel if you are interested in a formal legal opinion. Also, if I happen to mention a company or show some type of product, know that neither I nor CCHP has any type of relevant financial interest, arrangement, affiliation, or relationship with such a company. A bit of background about the Center for Connected Health Policy. We are a program underneath the Public Health Institute, and we were established in 2009 as a California telehealth policy organization. An opportunity to become the federally designated National Telehealth Policy Resource Center through a grant from HRSA became available in 2012. CCHP applied for that, we received the grant, and we've been serving in that capacity ever since. We also work with a variety of other funders and partners on the state and federal level on very specific connected health or telehealth projects. We also act as the administrator for the National Consortium of Telehealth Resource Centers, and we are the convener for the California Telehealth Policy Coalition. As most of you are aware, COVID-19 drastically changed the landscape for telehealth, both on the federal and the state level. Right now, in July of 2021, policymakers both on the federal and state level are trying to decide what of those temporary policies that they made in response to COVID for telehealth should be made permanent. Today, we'll be talking about some actions that Medicare has taken regarding those telehealth policies. So for those of you who are not familiar, the physician fee schedule is basically released every year around the summer, and it's proposing policies that will be in effect for the Medicare program for the following year. So proposals for 2022 are released now in 2021. Telehealth policy changes that can be made administratively, that means that CMS makes them without having to go through Congress, are typically made here through this process. They issue a draft proposal in the summer around July, sometimes August if they're a little bit late, and a public comment period is open for 60 days. It's finalized around that November-December time frame. So for this year, the proposed physician fee schedule was released around July 13th, and you have until September 13th to submit comments. So what is contained in that proposed fee schedule? Well, as I mentioned earlier, these are changes that CMS can make to the Medicare program regarding telehealth administratively. So they don't have to go through Congress. And one area that CMS can do that is deciding what services they will be reimbursing if it's provided via telehealth. Usually what CMS does is they pass the service that they are thinking of or proposing to be on the eligible permanent telehealth list through two types of tests. You can pass either on a Category 1 test or a Category 2 test. Now, Category 1 test means that the service that is being proposed to be put on the permanent eligible telehealth list is similar to another service that's already on that permanent list. A Category 2 test is the service is not similar to a code or a service on the permanent list, but there's a preponderance of evidence there to show that it could be effectively provided via telehealth and that it would benefit the patient. So for this year, CMS itself is not actually proposing any new services to be added onto that permanent list. It also receives comments from the public, suggestions from the public on services to put on that list, and it's received several. They passed it through the Category 1 and Category 2 tests and said none of the suggested services that were suggested by the public passed either test. So they are not proposing to put those suggestions on the permanent telehealth eligible list. Last year, CMS created a third category, a Category 3, which they said would be basically a temporary holding place for some of those temporary services that were on the COVID-19 list to be provided via telehealth. So when COVID-19 hit, CMS proposed adding a bunch of services that could be delivered via telehealth that Medicare would cover, but they would be on this temporary list, just there until the public health emergency was declared over. So in 2020, for 2021, CMS created a third category, and they put some of those services that didn't pass either on a Category 1 or Category 2 basis to be on a permanent list into Category 3. And these services, CMS essentially said, we would like a little bit more time to assess whether they can pass on a category 1 or a category 2 basis. So we're going to put them in category 3. That way, when the public health emergency is declared over, these services would not like automatically disappear like they would if they hadn't passed on category 1 or category 2. What would happen if they are in category 3, they'll stick around until the end of the year the public health emergency is declared over. So for example, if the public health emergency was declared over July 1st of 2021, all the services that were on the temporary eligible COVID list would disappear if they were not already like on the permanent telehealth list or if they weren't in category 3. The category 3 services will stick around until the year that public health emergency is declared over. In our example, they would stick around until the end of 2021. However, for in this proposed physician fee schedule, CMS is saying, we're actually going to extend that. For category 3, we're not going to say that you're going to stick around till the end of the year the public health emergency is declared over. We're going to say they're going to stick around until the end of 2023. So that was one change, one proposal that they're making. Also, they have said there are other services on that temporary telehealth eligible list for COVID that we did not put in category 3 or that we did not make permanent under a category 1 or category 2 test. If the public thinks some of those services should be put in category 3, let us know. So there's an opportunity there to provide comments. If you think some of those services that are currently on the permanent eligible list or aren't in category 3 should be moved over to category 3 and allowed a chance to stick around until the end of 2023, where more evidence, more information could be gathered to see if they can pass a category 1 or category 2 test. What is the big thing on this particular proposed physician fee schedule is around mental health services. There were a lot of changes on telehealth policy, but it was very focused on the provision of mental health services. One change is the Consolidated Appropriations Act. For those who are not familiar, this was a bill that Congress passed last year in December of 2020 that had some telehealth elements to it. And one of the elements was allowing mental health services to be provided without the geographical restriction and being provided in the home if the patient had a in-person visit with a telehealth provider 6 months prior to the provision of telehealth services. So basically, you would need to see your telehealth provider in person at least within the 6 months before they can start using telehealth to provide services to you, if you are trying to avoid that geographic limitation or have services in the home. Now, this is basically just CMS implementing what was directed by Congress, what's in federal statute, so they were putting that policy in place. One thing they did clarify in this proposal is that they said that the 6-month visit must happen. That requirement is there for every single telehealth visit. So for example, if you had a visit with your mental health provider within that 6-month period, and then you had a telehealth service, but then you did not have another telehealth service for like another 8 months, you would need to have like another in-person visit with them again. However, if you had like a in-person visit with that telehealth provider within the 6 months, and then you had like another follow-up visit with that provider like a week later, and you're still in that 6 months range when you had that in-person visit, you would not need another in-person visit. So you would need to like see them essentially 6 months, every 6 months for an in-person visit is sort of how it works out. The other thing that was added by the Consolidated Appropriations Act was emergency rural hospitals will also become another eligible originating site, and CMS said that they will start doing that in 2023. So one of the big things here related to mental health is audio only and providing services via audio only, but only for mental health services. So this year, what CMS has done is looked at audio only, looked at the data there, and what they found was they believe that you can effectively provide some mental health services via audio only very effectively. That there's also going to be like a great need for it once the pandemic is over. And there's also a concern of like shortage of providers to provide those mental health services and people accessing those services if they did not have audio only available to them. However, CMS has said in the past that they said, we really can't change the modality. We've got to wait for Congress to give us permission to change the modality and how services are delivered. That's why we've always said everything needs to be by live video. However, the way that the federal law is actually laid out, it says that telehealth is provided via a telecommunications system. It does not say specifically live video, it just says telecommunication system. And in federal law, there's no definition for what that term means. So CCHP and others have always said to CMS, it's not in federal law, defined in federal law. You administratively, CMS, have the flexibility to basically define what that means, what telecommunication system means, which means you can expand it out to different modalities. Up to this point, CMS has decided not to take that route. They've said that we really can't do that. They said that as recently as last year in the physician fee schedule when comments were made, again, reiterating, CCHP definitely did this, reiterating, saying like, you have that flexibility, you can include audio only. Last year, they even said like, we were sticking with like our approach, our historical approach to this. This year, because of sort of their findings on the data for COVID, concerns about people getting cut off for mental health services, they decided that they will redefine telecommunications system. And they will allow audio only to provide mental health services if certain conditions are met. So I really want to stress this. This is for only the provision of mental health services that you can use audio only underneath the Medicare program. Medicaid, private payers, that's a different story. We are only talking about Medicare. And Medicare has, or CMS has like been very narrow in their approach. They're saying for mental health services. So if you're thinking you can provide dermatological services via audio link, no, that's not what this says. It is for mental health services. And you need to meet certain conditions. So first off, it needs to be for an established patient. The patient has to be at home when they're receiving the services via audio only. The provider has to have the capability to do live video, but the patient can't do it or they choose not to do it via live video. And they're thinking, CMS's thinking was maybe they don't have like the capability to do live video because broadband, they don't have the connectivity for it or maybe the right equipment. And there has to be an in-person visit with a telehealth provider 6 months prior. So very similar to what we saw with what was in the Consolidated Appropriation Act, that in-person visit with a telehealth provider before you can provide services via audio only. So again, very narrow scope in where they're allowing audio only. It's for mental health services, and you've got all these conditions that you have to make. But this is something new. It does broaden things a little bit, and CMS has taken the step to actually redefine what telecommunication system is, something that, you know, CCHP and others have like long said that they have that ability to do. So while they're in the mood to redefine things, they've also decided to redefine things for FQHCs and RHCs. As many of you are aware, FQHCs and RHCs underneath the Medicare program aren't allowed to act as distance site providers. They are only allowed to act as originating site providers. That is in federal statute. However, during the public health emergency that was temporarily waived, and FQHCs and RHCs could provide services as a distance site provider via telehealth. CMS is saying that we also want to let FQHCs and RHCs provide mental health services via telecommunications technologies. Now you're saying like, wait a minute, how can they do that? Because isn't that like something underneath Congress's power to like change, like who could be a distance site provider? And that's absolutely true. The way CMS is going about this is they are redefining what a visit, more specifically a mental health visit, means for an FQHC and RHC. So FQHCs and RHCs have a very specific definition for what a visit is, and that's how they get paid. They get paid per visit. And in order to like get paid for that visit, they have to meet the definition of what a visit is. So by redefining it and including the terms, also include encounters furnished through real-time telecommunications technology, they've worked in the technology angle in there for the FQHC and RHC. Again, this is only for mental health visits. So we go back to our dermatology example. If somebody's trying to get a visit with an FQHC and RHC via live video, and it's for like a skin rash or something, that is not going to qualify. That will not work underneath the Medicare program. It's got to be for a mental health visit. There are some requirements that they have to meet, that basically that they would need to have like the patient like consent to using telehealth. So there's a few caveats, not as much as we saw earlier, but there are some caveats here. Now, the way that CMS has approached this is, again, not calling it telehealth, but like redefining what a visit is. They've gone the visit definition approach. So because they went the visitor definition approach, and they didn't say this is a telehealth visit because they can't change it, that's in federal law, it's not within their power to do it, those telehealth restrictions aren't going to apply in this case. So that geographical limitation is not going to apply in this case where it's a mental health visit being provided by FQHC and RHC via live video. So it's not regarded as telehealth. It does not have those telehealth limitations. Additionally, the PPS and air rates will be paid for this. So great. So now FQHCs and RHCs could deliver mental health services via live video or audio only. We'll get to the audio only part in a second. It's not regarded as telehealth for an FQHC and RHC. So that also means there'll be a different way to bill. And CMS said that they'll come out with like what you're supposed to do. But that also means like those telehealth limitations, like geography needs to be in a rural area, don't apply. So they decided to be fair and said, like, we're letting everybody else use audio only. We gotta let FQHCs and RHCs use audio only, but again, only for mental health services. And that is like if the patient cannot use live video or consents to use audio only. So it had like that little limitation there. Not as many as the previous sort of example that I gave for audio only for everybody else, where, you know, the provider needs to have like a live video, ability to do live video, etc. Basically, what was in the proposal just that the patient can't use live video or consents to use audio only to allow them to do this via audio only if an FQHC and RHC is involved. So again, this will be paid apparently by, it looks like by PPS and air rates. They're not going to get like the special methodology rate that FQHCs and RHCs saw during the pandemic, so they would be paid like their usual rates. CMS is seeking comments though on whether to require the 6 months prior person visit when you are talking about FQHCs and RHCs for audio only. They were hesitant to impose that because they said for the population that a lot of FQHCs and RHC shared, they weren't sure if that would be like an undue burden. So again, if you want to weigh in on that, they specifically called for comments regarding that particular idea. There were some other proposals in there, so this is just sort of a summary of them. They're going to do permanent adoption of G2252. This was the extended virtual care, the longer one, the one that goes beyond like the usual 5 to 10 minutes to 11 to 20 minutes. They're requesting comments about making certain supervisory proposals that they allow to be done via telehealth during the pandemic instead of in person, allowing that to be like a permanent policy, and people's thoughts on that. There are comments for separating coding and payment for medically necessary chronic pain management, and also revising the definition of primary care services in the shared savings program, and then a couple of other things as well. So those were like the major highlights that are in the physician fee schedule. CCHP is doing a fact sheet on it. So by the time this video is up, you can like go to our website and download the fact sheet for a little bit more details. But overall, it was an interesting physician fee schedule proposal this time. And also one of the more definitive types of moves toward permanent policies that we're seeing now on the federal level. A lot of things still would need to pass through Congress, but it was nice to see CMS using some of those flexibilities that we think that they had to do administrative moves, and using them to an effect and to improve and expand telehealth policies in the Medicare program. So I hope this was useful to you, and we will be seeing you in the next video. Thank you.